Hello everyone, my name is Ala Taha. I'm one of the PGY1 internal medicine residents, and today I'm going to be presenting our QI project about overutilization of amylase and lipase testing in acute pancreatitis. I will start with an introduction about diagnosing acute pancreatitis. So the diagnosis is often established by the presence of 2 out of 3 of the following criteria. Number 1 is the abdominal pain consistent with the disease. Number 2 is serum amylase or lipase greater than 3 times the upper limit of normal. Number 3 are the characteristic findings from abdominal imaging. Some statistics about pancreatitis. In the United States in 2009, it was the most common gastroenterology discharge diagnosis with a cost of $2.6 billion. When thinking about reducing the cost, while there are no substitutions for criteria 1 and 3, one way to reduce the cost is by using lipase only instead of both lipase and amylase, and this is what the guidelines currently recommend. Next comes the methods we used. The IHI model was used for this quality improvement project. A multidisciplinary team approach was utilized. The plan, do, study, act cycle was used to format this project and test change. A root cause analysis was done using a fishbone diagram. So during the first PDSA cycle, we tried using education. We educated the medical staff about ACG guidelines regarding amylase and lipase orders. In the second PDSA cycle, we educated residents, staff, and ED department about the guidelines. Finally, we noted that the ED-EMR order set for abdominal pain contains a pre-selected lab testing of both amylase and lipase. Here we can see our ED abdominal pain order set. On the left, it used to contain amylase and lipase. We reached out to our EMR specialist and we were able to remove the amylase from the order set. As we can see on the right, it now only contains lipase. So this is the fishbone diagram I mentioned earlier. Our problem was ordering amylase in the ED. Some of the possible culprits in the EMR system were amylase being part of the pre-selected abdominal pain order set. Other possible causes could be education, which we addressed in the first 2 cycles, which includes lack of education about the most recent recommendations and guidelines. Finally, systemic issues, which we think could be the busy emergency department setting, which makes it easier to just order everything and then take a look at the results later. Our goal for this PDSA cycle was to decrease the co-testing of amylase and lipase during pancreatitis workup by 40% in 1 year at our community hospital. So here I'm going to discuss some of the costs and how much we could potentially save with this project. The average cost of amylase and lipase testing is $35 and $70 respectively. We reviewed 98 patients' charts during a 6-month period who had abdominal pain and testing for acute pancreatitis was ordered. The total cost of ordering amylase for these patients would have been $3,430 without any intervention. So here we can see the results of our intervention. After changing the order set, there was a reduction of 47 amylase tests in a 6-month period. This led to a decrease of hospital cost and number of amylase tests ordered by 48% during that period. The cost of ordering these tests would have been $1,645. Now to the discussion part of the presentation. Following these EMR changes that we applied, co-testing of the amylase and lipase was significantly decreased. This method was more successful than education. We think one cause is the busy ED setting, which makes it easier and faster to use a standard order set. This shows us how important it is to apply system-based changes to make a significant impact. It is expected to save our institution approximately $3,290 a year. And what's interesting is that this method was not difficult to apply and did not lead to any extra costs to our hospital. Now to the conclusion. As we saw before, this method was successful in decreasing the number of amylase and lipase co-testing on admission. This shows us that system-based changes were more effective than education, and we were able to exceed our goal of 40% reduction in co-testing, and we reached 48%. Our next step would be to try to reduce testing furthermore by adding a pop-up whenever it's ordered. This pop-up would ask the ordering physician to specify the indication for ordering it. If they choose pancreatitis, a message would appear saying that lipase is the test of choice. Finally, I would like to thank you for your time and your attention.